So Dr. Francesca Raffi is a consultant gynaecologist at the University Hospitals of Derby and Burton. She's based at Queen's Hospital. She's part of our specialist gynae-oncology MDT, and she's been doing her postmenopausal and urgent care referrals in Burton since 2013. And we're delighted that she's going to speak for us today on endometrial hyperplasia.
Thank you. So I'm going to talk to you about endometrial hyperplasia. Endometrial hyperplasia is an estrogen-driven precursor of endometrial cancer. The causes of endometrial hyperplasia are chronic exposure to high levels of estrogen, which is unopposed by progesterone, and causes endometrial cell growth. So we can divide these causes into endogenous estrogen, excessive endogenous estrogen. This is more common in premenopausal women and includes obesity, where you get aromatase, which is found in adipose tissue, which leads to conversion of peripheral estrogen and leads to excessive estrogen levels. PCOS, where again we get higher levels of androgens, which are peripherally converted to estrogen. Chronic anovulation, infertility, and nulliparity. And estrogen-secreting tumors like granulosa cell tumors. Excessive exogenous estrogen is more common in peri- and postmenopausal women and includes unopposed estrogen due to HRT, tamoxifen, which acts as an estrogen receptor agonist on the endometrium, immunosuppression, early menarche, and late menopause. Other conditions which are associated with an increased risk of endometrial hyperplasia include Lynch syndrome, diabetes, smoking, and it's more common over the age of 35. Endometrial hyperplasia usually presents with abnormal uterine bleeding, and this includes menorrhagia, prolonged bleeding, sometimes shorter menstrual cycles, intermenstrual bleeding, and postmenopausal bleeding. And the diagnosis of endometrial hyperplasia is made by histology. An ultrasound scan can help in postmenopausal women to identify those who need an endometrial sampling. And in premenopausal women, if the endometrium is less than 7 millimeters, this makes it very unlikely that they would have hyperplasia. To obtain the sample, we usually use outpatient blind sampling, like a Pickel biopsy, which is convenient and has a high accuracy, especially for cancer rather than hyperplasia. Otherwise, we can use hysteroscopy, which might detect lesions like polyps. Again, the accuracy is higher for cancer than for hyperplasia. We use the revised 2014 WHO classification for endometrial hyperplasia, which divides it into endometrial hyperplasia without atypia and atypical endometrial hyperplasia. If we look at the progression of endometrial hyperplasia over 20 years to endometrial adenocarcinoma, this is less than 5% in patients without atypia, but 25% in those with atypia. It's important, however, to note that 40 to 43% of patients who have atypical hyperplasia already have an endometrial carcinoma at the time of diagnosis. If we look at the management of endometrial hyperplasia, this is based on the Green Top guideline, which is a joint guideline between the RCOG and the BSGE from 2016. If we start with endometrial hyperplasia without atypia, if we simply give expectant management, then 75% of patients will regress spontaneously, although it would be important to modify risk factors, for example, advising weight loss in obese patients or adjusting the dose of HRT, for example, making sure that the patient has an adequate dose of progesterone or has continuous progesterone. However, the first-line treatment and the treatment recommended would be a levonorgestrel containing intrauterine system, like a Mirena coil, as this delivers a higher level of progesterone locally ensures good compliance and gives less side effects than oral progesterone, and it has a very high regression rate of 89 to 96%. For patients who don't want a Mirena coil, continuous oral progesterone is another alternative, which should be taken for a minimum of 6 months. This includes, for example, medroxyprogesterone 10 to 20 milligrams daily, or norethistron 10 to 15 milligrams daily. It is, however, less successful at reversal of the hyperplasia, and it has a higher relapse rate, especially in patients with high BMI. Surveillance should be offered to patients, and they should have a biopsy every 6 months, with a minimum of 2 consecutive negative biopsies before they're being discharged. And we should consider an annual biopsy if the high risk persists, for example, in patients with very high BMI. Hysterectomy can be offered to patients who progress, those who do not regress within 12 months, as they will have a higher risk of an underlying cancer and a lower chance of regression later on. Those who relapse, those who have persistent symptoms, for example, bleeding, or if it is the patient's preference. A BSO should be offered to all postmenopausal women and should be considered for premenopausal women, or at least the tubes should be removed in all women. And endometrial ablation is contraindicated, as we cannot guarantee that all the area has been treated, and it would be very difficult to monitor women afterwards with a hysteroscopy or biopsy. If we look at the management of atypical endometrial hyperplasia, we usually recommend a hysterectomy. This should be done laparoscopically because of the quicker recovery and less pain associated with the procedure. And BSO should be offered to all postmenopausal women and should be considered for premenopausal women due to the high incidence of cancer in these patients. If patients want to retain fertility or not fit for surgery, then they should be taken to the MDT. We should rule out invasive cancer or coexisting ovarian cancer, and we should offer them a coil with a 3-monthly biopsy. We should await for reversal of the changes before conception, as there's a high implantation and pregnancy rate if these changes have reversed. And sometimes assisted conception may be considered to quicken the process. And then a hysterectomy should be offered after the family has been completed. If we look at some more particular cases, so for patients on HRT who develop hyperplasia, they should be asked to stop the HRT ideally. However, if they wish to continue, then for patients on sequential HRT, we should offer Mirena coil or change them to continuous combined HRT, and we should monitor them again with biopsies as discussed previously. In those of continued combined HRT, the evidence is a lot less, so we should discuss the limitations of our evidence, and we should again offer them a Mirena coil. But ideally, all these patients should stop the HRT, and we should treat them as per previous slides. Patients on tamoxifen have an increased risk of hyperplasia, and the risk is increased depending on the dose they use and the duration of treatment. And this is especially the case in patients over 50. So if these patients develop hyperplasia, they should be taken to the MDT, and we should discuss the management with the oncologist, see whether they need to continue the tamoxifen and discuss the options in the MDT setting. If hyperplasia is found in a polyp, then the polyp should be removed fully, and we should curette the background endometrium. There is an increased risk of hyperplasia in the background endometrium, and therefore often these women are offered a hysterectomy. But again, it depends on the type of hyperplasia, and it should be managed as per previously discussed management plan, depending on whether there is atypia or not. Thank you.
Thank you very much, Francesca, for a fantastic talk. Well, I have a question. I was going to ask, have you ever come across in the spectrum of hyperplasia, morular hyperplasia? We've had a couple of cases of this come through the MDT, and I just wondered sort of what your experience is of the management of that.
Morular, you said?
Mm-hmm.
No, not really. Sorry.
That may be a question more appropriate for
Yeah.
Rand Havari. So we, hold that thought there, Susie. I'm sure Rand will enlighten us about that. Rand, can you jump in there?
Yes,
Morular
of course.
hyperplasia.
Yes. Yeah, good morning, everyone. Nice to see so many familiar faces. So what do we mean by morular hyperplasia? That means there's a lot of squamous morular differentiation on histology. So you see a lot of squamous differentiation. When you see them, you get worried that there's maybe an atypical hyperplasia hiding somewhere. So I think of it as something that if you don't have cytological atypia, but you have a lot of squamous morules, it's better to follow up really closely. But it doesn't mean that it definitely needs a hysterectomy. I think of it as a slightly more worrying features of simple hyperplasia without atypia. Make sense? That's how I think of it. So I usually put an advice in the report saying this is really like I will ask for a repeat biopsy or maybe an endometrial curettings. When I see it definitely on the histology, what I do, I immediately cut DBAL levels to make sure I'm not missing cancer or atypical hyperplasia focally that can be hiding on the slide, and it just need a little bit more attention. That's basically it. But it's quite rare to be seen, to be honest. It's not very common. So
if it was on Rand, if it was on a PIPEL, would you advise a hysteroscopy and a curettage?
I would.
Yeah,
Especially if it's really extensive and there's other risk factors, like, for example, obesity, patient that's slightly older. I get worried that this is maybe something more, something more sinister hiding somewhere, and that just need a little bit more attention.
Thank you very much.
And would you advise, would you advise that we treat it with progesterone, or that we just follow it up with serial biopsy?
No, definitely treat with progestogen. Yeah, definitely.
Okay, thank you. Ismail, would you want to ask your question? You're muted, Ismail.
Having a hyperplasia without atypia, everybody thought that it is okay, that's fine, there's nothing to worry about, but it's 5% of them will progress to cancer. And I think we need to enforce the fact that we need to follow those patients more closely than before, because I've seen some of them actually got lost because they were reassured and sent home saying, "Oh, you got a simple hyperplasia, we'll have a marina, and then it can be removed after 6 months, and then we do the biopsy, and then if it is negative, we don't follow them up again." I think we need to reinforce the fact. So what do you think?
It depends on the patient. So if they're kind of low risk, you've had 2 negative biopsies, so you do definitely need to follow them up with biopsies, and you've had 2 negative biopsies, and you can't discharge them and advise them to come back if they have, again, abnormal bleeding. But if the high risk persists, for example, if they're very obese or those kind of patients, for example, then you may want to continue with yearly biopsies long term.
The other thing, Ismail, I think, is you've got to manage patients symptomatically as well. People forget that. They've got heavy bleeding and ongoing problems, and they're perimenopausal, and then you've got to manage them symptomatically.
To be honest, I'm talking about a specific patient who she got PCOS, and she's very obese, and she's only 25. And the first biopsy taken showed a simple hyperplasia, and after treatment with progesterone, because she refused Mirena, the biopsy after that came with a typical cells.
I mean, she's already high risk, isn't she?
She's very high risk.
Shall we take
and the
one more
oral
question?
progesterones are not as effective in obese patients. They have a much higher relapse rate. It's about 30%. So,
Thank you. Shall we take one more question? Ian, did you want to ask your question?
Yeah, thank you very much, and thanks for the talk so far. It's been a really excellent start to the day. Just a quick question, if that's all right. I wonder if you could clarify the guidance around finding endometrial hyperplasia in a polyp, which I know you touched on. my interpretation of the guideline has always been that if the hyperplasia is confined to the polyp and the background endometrium is normal, you act on the background endometrium. But we've had some discussion in our department, and some of my colleagues in my department have a slightly different view. So I just wondered if I could get your thoughts on it.
There is an increased risk, so about 50% will have abnormal cells in the rest of the endometrium. So it really depends on the patient, what their history is, what the risk factors are, how old or young they are, what the fertility options, whether they want to maintain fertility or not. You have to kind of individualize it. The guidance does say that if the background endometrium is normal, you could just, and you're sure you've completely removed the polyp, you could just monitor them. But there is a higher risk that you might have missed some hyperplasia in the rest of the endometrium. So if they're a bit older, they've completed their family, then you might want to offer them a hysterectomy.
It boils down to the age of the patient, doesn't it, Ian? I think, you know, if they've got not a huge number of comorbidities and they're peri or postmenopausal, then the safer option. I mean, keyhole hysterectomy is so routinely done, certainly in our department, and a very safe procedure that it just seems. So our routine would be to offer a keyhole hysterectomy if they've completed the family. Obviously, if they want to maintain their fertility, as Francesca rightfully says, you may imagine conservative, but the default would be to still say that. Yep. Okay.
Excellent.
Shall we move
Cheers,
on?
thank you.